So now we want to focus on measurement in low and middle income countries.
So when we started this, we decided that an important first step was to try to adapt existing measures from high-income countries and evaluate their use in low and middle income settings. We decided on 3 measurements that assessed constructs that we were interested in and had some good psychometrics. So you see here, we used the dimensions of organizational readiness for change, and the evidence-based practiced attitude scale. We did this in Iraq, Zambia, and the Thailand-Myanmar border. Our psychometric results from these studies were very mixed. The measures did not work very well across multiple stakeholder levels, and we found that many items didn't cross over to these low and middle income settings. We also received feedback that the instruments were very long. As a group, we found ourselves wanting more constructs evaluated across multiple stakeholder levels to get a better picture of what was actually happening.
Given our pretty clear results that taking Western measures didn't work as well as we had hoped, we decided to try again. For the second attempt, we decided we would develop our own measure that would be specific to the context of low and middle income countries. To do this, we used 7 steps, beginning with a strong focus on our outcome definitions, through ultimate development, piloting, and finally testing of our instruments. To start, we went back to the definitions. However, when we focused on these, we decided we needed to operationalize them further for the context we are working in. For example, as Laura mentioned, adoption was defined as the intention, initial decision, or action to try or employ an innovation or evidence-based practice. We added the engagement or disengagement with the innovation through implementation. We thought that adoption is not always an initial decision, but rather a decision to continually engage in the program. For feasibility, it was previously defined as the extent to which a new program or policy can be successfully used or carried out within a given agency, in a particular setting, or in a certain population. We thought this was too theoretical, so we tried to add more specifics, as in it takes personnel, money, time, buildings, and furniture. As Laura has mentioned throughout this webinar, multiple stakeholder levels is important to implementation science. When we talk about this, we are defining a consumer as a person who is receiving a service, a provider, a person who is directly providing the service to the consumer. An organization is the local organization that directly manages the provider, and the government or policy level are the participants that have overarching responsibility for multiple local organizations. We believe that all of these types of stakeholders play a key role in implementation of programs, so it was important to be able to measure implementation outcomes from each perspective. After defining our outcomes, we returned to the major theoretical frameworks to help us in better understanding the process of implementation and the components that go into implementation of programs. With the Proctor model guiding our outcomes and definitions, we also consulted the Consolidated Framework for Implementation Research, the REAIM framework, Reach, Effectiveness, Adoption, Implementation, and Maintenance, and the EPIS framework, Exploration, Preparation, Implementation, and Sustainment. These frameworks helped us in fleshing out the content of each outcome. Using these theoretical frameworks, we mapped the constructs that were delineated in each of framework to our outcomes. For example, in our acceptability outcome, we grouped constructs from the CFIR and EPIS framework. In CFIR, they talk about the compatibility of the intervention or the relative priority of the intervention. Both of these concepts we grouped under our acceptability outcome. This process helped us in thinking through what constructs would need to be covered under each outcome. Finally, we use log frames to help us in linking together our constructs and ultimately developing indicators for these constructs. For example, the constructs from the theoretical frameworks were grouped under intermediate results. We then generated specific indicators to act as the measures for these intermediate results. This also helped us better lay out where we would obtain the data for each indicator. We repeated this process for each outcome and for all stakeholder levels. Ultimately, we ended up with a log frame for acceptability for consumers, providers, organizations, and policy, a log frame for adoption for consumers, providers, organizations, and policymakers, and so on. The indicators we specified in the log frames became our items in our draft instruments. Here is an example of the acceptability scale.
That's right, Emily. And so in the process of developing an instrument for implementation in low and middle income countries where there were no or very limited services, we also wanted to include a step of expert review. We consulted with several implementation science experts to determine whether we were missing any major domains or questions. In addition to our applied mental health research group, experts in low and middle income countries, for example, Dr. Vita Toll and William Weiss, who have been doing global work in low and middle income countries for over a decade. We also consulted with mental health experts who do implementation research in both high-income countries and low and middle-income countries. For example, Dr. Helena Verdelli. And also with implementation research experts such as Dr. Ross Bronson and multiple fellows from the IRI. Several questions, particularly related to organizational culture and climate, were added to the draft questionnaires.
Thanks so much, Laura. So after all that formative work, we then pilot tested the draft instruments in Myanmar and northern Iraq and Kurdistan. We conducted quantitative survey interviews with consumers, providers, organizational level directors and staff, and people involved in policymaking. We also conducted semi-structured interviews with these stakeholders as well. Here's a more specific breakdown of the number of participants that we interviewed. As you can see, we had the most number of participants at the consumer level, with sample sizes getting smaller for different levels of stakeholders. Of particular note is our very low sample sizes for organizational level in Myanmar and policy level in both sites. These sample sizes prohibited any quantitative data analysis, so I will only discuss the qualitative results from those levels. So let's back up quickly to give you a frame of reference. For those of you who are not as familiar with statistics, one very coarse measure of how well scales are performing is the Cronbach's alpha. This basically just tells us if the items in a scale seem to hang together well. In other words, do all the items in the scale seem to be measuring the same thing? This is by no means a comprehensive measure of a scale's performance, but for a pilot study, it at least tells us if the items on our scale seem to be cohesive and consistent. Generally, when we look at alphas, we're looking for a value above 0.7 to be considered acceptable. As you can see from the consumer results, many of our scales did not perform that well. For example, our smallest alpha was for the feasibility scale at baseline. Our highest alpha only reached 0.8 for the penetration or accessibility scales. Now let's look at the provider level. At the provider level, we got slightly better results, particularly in Myanmar. But again, you see a wide range in alpha levels, suggesting major revisions to the scales for providers were warranted. Finally, at the organizational level in Kurdistan, we again see these wide range, from 0.36 for willingness to change to 0.89 for autonomy at the follow-up time point. This all suggests that more work needs to be done. As for the qualitative results, participants in Myanmar pointed out several facilitators to well-implemented programs. Consumers found that the counselors were flexible and willing to adjust schedules to fit clients' needs. They liked that the counseling relieved their problematic feelings and helped them to overcome problems. They found that CETA was suitable for the culture in Myanmar. Among providers felt like the CETA program is effective. They reported positive relationships between themselves and their supervisors, and they found it useful that they share similar backgrounds with their clients. At the organizational staff level, participants discussed the fit of counseling with local values, and that as people became more aware of the program, its acceptance seemed to be increasing. At the policy level, participants again discussed that counseling services seemed to fit a need in the population. In terms of barriers to implementation in Myanmar, consumers spoke of a lack of awareness of the program, stigma and logistical issues including lack of time and money to get to services. Providers talked about logistical issues with finding private spaces, and reliance on donor support for the program to pay them. Organizational personnel also worried about funding and lack of government support for the program. While at the policy level, concerns related to the limited nature of the program in its current form, which was only in one language and was mostly delivered to a certain population. In Iraq, at the consumer level, facilitators included a fit with local values and the needs of the population. Consumers reported that they had good and trusting relationship with the counselor and that flexible timing and scheduling was important. Provider and organizational levels, a positive work environment was the most frequently mentioned facilitator, along with the counselor feeling good about providing the services. At the consumer level, barriers included struggling with logistics, low awareness and stigma in the community, and not feeling comfortable with the counselor. At the provider and organizational levels, logistical challenges were problematic, lack of government support was seen as particularly challenging, and stigma and shame emerged as issues for both providers and organization. Looking across both sites and all stakeholder levels, major facilitators of well-implemented programs included having flexible schedules, positive relationships with the counselors, the fit of the service with local values and needs, and the importance of the counselor and supervisor relationship. Barriers included problems with logistics, low awareness and stigma, the duration of treatment, lack of government support, lack of sustained funding, and problems with securing private space. We used this qualitative data to find areas and items that we needed to include for mental health programming in LMIC. In other words, these are things that were important to the population, that affected their views of the program, and we wanted to make sure we captured this in future iterations of the instruments. Given the poor quantitative performance and issues that emerged from the qualitative study, we revised our measure. To revise the measure, we retained any well-performing items from pilot testing. We developed more items based on the qualitative study. We reworded items so that they were more neutral. So instead of saying, "I like providing the program," we said, "Do you like providing the program?" We also removed any reference to a specific program to allow these to be customizable to different settings. And finally, based on some of the qualitative data and newer literature in dissemination and implementation, we added and adapted scales on leadership and capacity for sustainability. So our final measure for testing includes scales on acceptability, adoption, appropriateness, feasibility, reach, capacity for sustainability, organizational culture, and leadership. The final step in our process was to test the measures. But how do you test them? As Laura brought up, we are often working in settings where most people we work with across stakeholder levels are unfamiliar with a variety of mental health programs. How then do we know if our instruments are capturing different levels of implementation, if respondents do not have experience with different levels of implementation? To overcome this challenge, we used a vignette method, in which we presented a hypothetical situation to participants for them to respond to. As part of our ongoing work in Ukraine, we administered our implementation measures to potential consumers of mental health programs. All of our participants were either internally displaced persons or veterans of the Ukrainian military. We also tested our provider measure among a sample of 151 providers through an online survey. Most of these providers were school-based psychologists, clinical psychologists, psychiatrists, and social workers. For the study, we developed 2 vignettes. One described existing psychiatric care in Ukraine, which was widely considered to be problematic. The other depicted a community-based psychotherapy program. We then randomly selected half of our participants to receive the psychiatric vignette and the other half of the participants to receive the psychotherapy vignette. Finally, we also asked participants to rate the program depicted in the vignette overall by providing them with a definition of the outcome and asking them to say how well the program in the vignette met that definition. For example, we provided them with a definition of acceptable as being a program that is satisfying and agreeable. We then asked participants to rate the program in the vignette on how much do they think the program described in the vignette meets that definition of acceptable. Our hypothesis was that a well-implemented psychotherapy program will be more likely to be adopted and viewed as acceptable, appropriate, feasible, and accessible compared to the psychiatric care by potential consumers and providers in Ukraine. Basically, what this means is that we hope to see higher scores for the people that read and responded to Vignette 2 than the participants who read and responded to Vignette 1. We also expected that higher scores on the scales would be associated with higher overall ratings for each of the specific outcomes. In general, results for both consumers and providers indicated good reliability and validity. These are the consumer results. I'm going to walk us through these graphs. The first shows average scores on each outcome scale by vignette. Again, for our hypothesis, what we wanted to see were significantly lower scores for those who rated the psychiatric vignette, the green bars, than for the vignette depicting the community-based psychotherapy intervention, the blue bars. In this graph, you see that ratings were universally higher for the psychotherapy vignette compared to the psychiatric vignette. Now, when you look at the second graph, this is comparing average scores on each scale by the overall ratings of whether the program depicted in the vignette met the definition for an adoptable, acceptable, appropriate, feasible, and accessible program. Again, we see here that scores on each scale were significantly higher for those that rated the program highly on these outcomes compared to those that rated them lower. These results show that our measure can capture some variation in implementation quality and supports their validity in this context. Analysis of our provider survey is ongoing, but preliminary analysis suggests similar results.